Good afternoon, ladies and gentlemen. Good afternoon and welcome to the second online event organized by the European Public Health Alliance, EFA. I'm Yanis Natsis. I lead our work around vaccine equity, which is a very high priority for the European Public Health Alliance. And today's event focuses on one of the pillars, one of the key themes of vaccine equity in Europe and beyond, and that is confidence in vaccines. It is a very timely discussion. Anyone, what we need to do is just read the news on any given day, these weeks and months, and we will understand why confidence, trust in vaccines is so fragile. Before we proceed, you should know that the discussion is recorded and you can watch it online on the YouTube channel of the European Public Health Alliance, EFA. Please feel free to engage on Twitter using the hashtag vaccine confidence and vaccine equity. And it's a great pleasure to be joined today by these four intellectual powerhouses to have this conversation and to focus on what can governments, but also what can the EU do from now on, looking ahead, in order to boost confidence in vaccines. We will hear from Professor Heidi Larson. Welcome, Heidi. It's a great pleasure to have you with us. Professor Heidi Larson, she's an anthropologist. She's the director of the Vaccine Confidence Project. Please, if you haven't seen the Vaccine Confidence Project, go and check it out. It's a wealth of information at the London School of Hygiene and Tropical Medicine. And Heidi Larson also published a book called Stuck, How Vaccine Rumors Start. Voila, this is the book which was out, if I'm not mistaken, it was out shortly before.
It's in a weird space here.
Yes.
Yes.
Stuck, How Vaccine Rumors Start and Why they Don't Go Away. So that shows that the issue is not new. It's not because of COVID-19, but obviously with the current pandemic, and the discussion around vaccines, this is the time to discuss about what we can do in order to boost the confidence in vaccines. So thank you very much for joining us. Deborah Coyne, you know her, you see her on BBC's Newsnight. She is the BBC health correspondent. You've previously seen her on agenda-setting news programs such as BBC's Panorama, but also with her investigation pieces for the British Medical Journal. Welcome, Deb. Lovely to have you with us. Valérie Paris, she is one of the 7 members, she's an economist, one of the 7 members of the board of the college of the French National Health Authority, La Haute Autorité de Santé, which is an advisory body in France, but also a decision-making authority. And Valérie will explain to us, previously she was working again on health systems and pharmaceuticals for the OECD. And Valérie will give us the perspective from a member state, from the perspective of the HAS, the French National Health Authority. And last but not least, our president, the president of the European Public Health Alliance, Alice Chapman-Hatchett, who of course is also the director of the Health in Europe Center and an IFA member, and obviously our president. Thank you so much for joining us. I know that you are all 4 of you are super busy these days. Professor Larson, Heidi, if I may start with you. With all the news I hear and I read every day, I have the right to feel nervous, right? Even if I'm pro-vaccines, obviously. It would be interesting for our viewers to understand what is the nuance between vaccine hesitancy and the anti-vaxxers, for instance. Over to you.
Thanks so much. Well, that does get confused. I think the term anti-vax has been used and abused. I think it's also contributed to some of the polarization that's going on because people who are really have some genuine questions in the middle, as it were, between we choose the frame of confidence in the Vaccine Confidence Project because you can be 0% confident and you can be 100% confident, but it gives you that spectrum. And I would put the hesitant people in the middle there. Sometimes we talk about it as the movable middle. In political terms, you talk about your base, your pro group, your opposition, which might probably in this case be the anti-group, and then you have your swing vote in the middle, as it were. And they have, particularly in the context of risks, as you said, very legitimate questions sometimes. And I think we have to be careful not to judge or alienate them by saying, giving the impression that they're an anti-vaxxer just because they asked any questions. And that's become a real issue among some of parents, but I know also in the context of COVID, we can harden those who really are potentially willing, but really have some genuine questions. So I think we have to listen more. The other, and even if we don't necessarily agree, help people navigate some of the complexity. The anti-vaxxer groups, frankly, most of the people who are questioning or even refusing vaccines resent being called anti-vax because they feel like they're not against vaccines in general. They have particular issues. I think it's more specific to groups that are propagating, as we call disinformation, which is different from misinformation, which is mistaken information, sometimes shared without knowing that it's actually not correct. It's misinterpreted or misinformed. But disinformation is more purposefully motivated to disrupt, to polarize, and to turn people against something that the government is providing. And that's more the anti-side. But on just a last point here, the very first anti-vaccine group was actually the Anti-Compulsory Vaccine League, and that was in the 1800s in the UK. It was a group that organized in reaction to the government making smallpox vaccination compulsory. And that theme of freedom of choice, liberty, has been a very strong driver of hesitant and refusing groups over the last centuries.
Yeah, and thank you, Heidi. I mean, you touched upon several topics there. How is the situation right now in Europe? Are we overly gloomy when it comes to vaccine hesitancy? What do you make? I know at the Vaccine Confidence Project, you conduct a lot of surveys, detailed surveys, looking at different member states and countries. Give us a snapshot, if you may.
Well, we launched our first global vaccine confidence study the research was done in 2015 and published in early 2016. But that was using our Vaccine Confidence Index. That was the first global study with our index. And that found that Europe was the most skeptical region in the world, with France being the most skeptical by not a small margin. But in the meanwhile, the EU has asked us to keep monitoring every 2 years the confidence in Europe, and in the meanwhile has really organized I think an impressive effort to try to address and understand hesitancy across the region, and France in particular, as in its own way, has tried to address this. And we have seen in our 2020 study that there has been a shift towards more positive overall confidence, although there remain pockets of concerns and issues, particularly more in some of the, like Poland and some of the more Eastern European countries.
Thank you. Deborah, you've been reporting throughout COVID-19, and it's extremely hard to keep up with everything that is happening. And I think there is a lot of uncertainty, a lot of question marks on several fronts. And obviously, vaccine hesitancy also grows when there is increased uncertainty. But from a first perspective, from all your investigations throughout the past year, how hard has it been to talk about the truth, or let me rephrase, about scientific or science-based and science evidence-based truth?
Thanks, Yanis. First to say, this is probably the hardest reporting I have ever done, and I've conducted investigations British Medical Journal, and Panorama, real complex investigations. And part of that is information's moving so quickly, and you've got, not only do you have your normal journal articles, you've got preprints, you have press releases, and also what's happening, and I've covered health and science for 12, 13 years, is you've got a lot of political correspondence, and it's been the only game in town. And what's that? I know where to go to look for evidence. I know how to interpret evidence. Doesn't mean I always get it right, but I understand, p-values and confidence intervals. I understand uncertainty, and to a greater or lesser extent, I know how to communicate that. But what we've seen is a real mixing of scientific evidence and politics, and people getting briefings and decisions being made politically, because obviously we're in a global pandemic. And I won't comment on the ins and outs of that, but that's been incredibly tricky. And people sometimes think they do the right thing. So headlines on one red top newspaper talking about the very low risk of a blood clot associated with the AstraZeneca vaccine, and it put a specific number in it. And I ended up having a bit of a Twitter debate with some of the new scientists. He thought that was really good science journalism. I didn't, because I don't think you can put a point estimate on yellow card reporting, because that might change. And I think what people are seeing for the first time is how quickly science moves, how quickly science changes. And I think when it's come to my reporting, and I'm not saying I've got this right, it's always very cautious, because if you go in too hard, it means you can't really change when the evidence moves, and you have to be transparent. So when the first vaccine phase 3 trial, that the Pfizer vaccine, that came through on a press release, and I naturally am very, very cautious of reporting on press releases. I don't, as a general rule. I want to see the full study, if at all possible. I want to see the confidence intervals. I want to see some different subgroup analyses, if that's available. But that's all I had to go on. The only thing I could do was say to the audience, this is based on a press release. We haven't seen the full data yet. Data will be submitted to the regulators. But so far, this is what we know and we understand. And as well as what we know, this is what we don't know. This doesn't tell us the impact on transmission. This doesn't tell us what we know from the protocol of the phase 3 trial is we tested it on these people. We don't know how effective it is against with older people. We don't know. This might be the bulk of the result is driven by younger people. We don't know about different ethnic groups, say, for example. So all you can do is just be honest about what you know, and then there's other tricky things. So when Norway started flagging a signal with blood clotting, do you report it? How do you report it? If you don't report it, and this happened, or when Norway decided to be cautious with use of the Pfizer vaccine in older people, how do you report that? Is it relevant to the UK? So a lot of political people say, oh, that's just Norway, but I know that Norway has a very good pharmacovigilance system, so we'll listen to it. But how do you report it? When do you report it? Because if you don't report it, it looks like withholding information, because we've got the internet, we've got Twitter, these things get out. So every little thing is considered. It's actually one of my least favourite subjects to report on vaccines, because you have to be honest and upfront. And when I complained about, I didn't like the fact that I had to report off a press release with this was on Twitter, off a point estimate, and that doesn't make me feel comfortable. I got called an anti-vaxxer. No, I'm not at all. But that, and it's from doctors in America, and you're not help. And I'm like, but being overly certain at this point isn't going to help either. Because then if people have a vaccine and then get infected, but they've been told it's 100% effective, what does that do? I mean, Heidi might have the answers to those questions, but these are just the things that are going through my head as I'm reporting. And then on top of that, we've had a layer, certainly in the UK, and I've seen it in other European press. There's been a layer of political briefing on top of that, and all of that is really, really, really tricky, and it makes reporting on vaccines difficult. difficult, but all I can do is be transparent about what we do and we don't know, and where the information's come from, and any uncertainties. And also to use the word safe. What do we mean safe? I mean, what we tend to mean in medicine is the benefits outweigh the harms. So it's just explaining all those terms all the time to people and making sure you're clear about what you do and don't know.
Thank you, Deb. And certainly, yes, it's the importance of being transparent. I think that, but you just talked about this, and that brings me to my question also to Heidi, and then I'll go to Valerie to get a bit of the perspective from a decision maker. Heidi, do we fuel or do we create a vaccine hesitancy by talking about it? And what should we do? Is censorship the way, or what is the solution?
Well, I think that the worst thing to do is not talk about it, because then it goes underground. And I think the problem is that I think we've gotten to this point is because people haven't wanted to talk about it because of the anxiety that it causes it. I mean, that it might provoke, but I think it's all about how you talk about it. It's not, and that also is it gets back to that risk question too. How do you handle risk? Publics can handle risk. What they can't handle is lying. They can't handle not knowing what's going on. There is this issue, though, of deciding when do you share it? When is enough enough? You don't want to contribute. I mean, rumor by definition is a piece of yet unverified information, which could talk about the whole COVID situation right now. But I do think it's about how we talk about it. And if we start to say these risks have been reported, you will be hearing about them. We are in the process of learning more. So don't say, oh, it's a little risk, but don't worry, this is normal. The worst thing that's been happening is scientists saying, oh, this is normal. Well, it's not normal for someone who's been affected, even if it's only one. And it just sends this message that, the scientific community has zero empathy and they're just defensive. And that's part of what has been this challenge. So I also think it hasn't been great that in a sense that, on the one hand, the UK has been first and out there, and then there was an even article about a UCL scientist who was the first to notice these blood clots, and it's raised a lot of people calling me and said, wait a minute, if we had the first person to notice this and we were one of the last to be confirmed here, something's not right there. So there's a lot of, so I think put it in the context of a story. Say we're on this journey together. This is the beginning of more information we're going to be getting. Remind people that there have been over 800 million people around the world vaccinated against COVID with one of these various vaccines. We're lucky that these issues hadn't come up earlier. So that's a social proof of the overall benefit of these vaccines. And just, I think, putting things in context more. So I would say to that question, it's all about how you say it, but we shouldn't hide it.
Very clear. Thank you, Heidi. For Valerie, in France, you at HAS, you have an advisory role. Correct me if I'm wrong. You put out guidelines. You advise the government, for instance, on who to vaccinate, who to prioritize, how to organize the vaccination campaign. You joined HAS, if I'm not mistaken, last year, so in the midst of the pandemic. What has been the challenge? I mean, was it, we do things as we usually do them, and when it comes to vaccination, is this something that we maybe we need to learn from our previous lessons and mistakes and go about the vaccination strategy differently? What have been your thoughts so far at HAS in France?
Yes, so to be very precise, HAS has an advisory role, as you mentioned, but there is another, for this specific crisis, there is a specific advisory board which is closer to the government and which advise and generally follows our recommendations, but in some few exceptions, they also departed from them. And I also forgot to mention that when I joined the HIS, I joined the vaccine committee. So I've been contributing to these discussions between vaccine experts, which have been fascinating for me because I was not a specialist in, vaccine. And a lot of these people, which are experts in public health, infectiology, virology, and so on, also have worked a lot on vaccine hesitancy because, as you mentioned, it has been a very strong issue in France to be addressed. So I learned a lot about all of this, and at each step of the recommendation and publication of our work, vaccine hesitancy and even anti-vax was, very prominent in all the recommendations we have made and so on. So what we decided was to be as transparent as possible and to promote transparency at all steps of the vaccine strategy. Even if sometimes, it appeared to block the situation. I will give you an example. In the first recommendations we made about vaccination, we spoke about make sure that the patient was informed and consented to the vaccination. But in our mind, it was only an oral, like what you should do for every medical act, actually, because you are not going to do anything to a patient without getting the consent. But in some instances, it was interpreted like in nursing homes as getting a written consent from the patient. So it was very difficult to obtain, and it was adding a step to a vaccination which was, urgent. We had a lot of people dying and infecting in nursing homes. So we had no time, to take 1 week for written consent or so on. So it should be consent, yes, for every medical intervention. We should have the agreement of the patient, but not more than that. So it was just one example where the fear of, facing, I don't know, perhaps legal suit from parents of residents, or because there was also this problem of consenting for people who cannot consent to anything because they have, Alzheimer's disease or other things. So it was very, very complicated. And at the end, when we look at the results about the rate of vaccination rate in nursing homes, it's now very close to 100%, which means that this fear of having many people not consenting to vaccination was in part overestimated.
Thank you, Valerie, and thank you for this reality check from the ground. And I like that because it allows me to go to Alice. I think for us in the public health community, this is the challenge of communication and what sort of information and at what point. But also, I would like to really bring into our conversation today to focus a bit on the needs of vulnerable populations and vulnerable communities, because this is the time, actually, it's already a few months now, where governments and the European Union on the Brussels level need to consider what to do and how to reach disadvantaged communities on the ground. And of course, the practical barriers, in Belgium, we get an invitation to go to get vaccinated with a QR code. But a lot of these populations, there is no address to send this convocation, this invitation, or people don't have access to the internet. Also, the senior citizens may not even know how to use a smartphone. So, Alice, over to you. How do we bring the needs of these populations into the policy discussion?
Thank you, Yanis. I think the first thing that we need to start with when we're thinking about vulnerable groups is why they are vaccine hesitant. What are the specific circumstances that relate to them? And I think you've touched on a few of them, but it is, once you start really looking into this, it is much wider than a sort of a cursory glance might imagine. First of all, you think about things like lack of access to good or independent information. That's also true for the general population. But then you start thinking more about things like perhaps general skepticism of the social system. They may have had interactions with the social system in the past. For example, if you think about the homeless community, where they've actually come off worse. They've gone to a system for help, and the system actually hasn't been able to give them the help and the support that they needed. So therefore, you've got a natural inbuilt skepticism already in some vulnerable groups. You've then got the issues around administrative barriers. They may not have the right documents. They may not be registered with a family doctor. And actually, hesitancy is easier than addressing administrative barriers. So you may have the hesitancy caused not by hesitancy in itself, but because it's the easier option rather than actually proactively doing something in order to get a vaccine. You also then have things like chaotic lifestyles. I'm thinking here particularly around undocumented migrant sex workers. If their lifestyles aren't organised in the ways that you and I might recognise, again, this is another barrier to them being able to take up a vaccine. So I think that the hesitancy side of this is perhaps not so much hesitancy per se, it's a series of other areas that impinge and impact so much on these vulnerable groups that it means that not getting the vaccine is actually the easier option for them. And in terms of then, what can we do? I think here we really need to think about reaching out to them. You've highlighted, Yanis, the issue about having a mobile phone and scanning a QR code. I mean, for some vulnerable groups, the very idea of having to go somewhere else to a mass vaccination centre for an appointment is just out of the question. If they are very poor, they don't have the money for the bus fare, and it's literally such practical, tangible things as that. Get the vaccine to them. Picking up on what Heidi, you were saying earlier around trust and confidence, I think when you're talking about vulnerable populations, I mean, this issue is amplified even further. It really is a case of using people that they know and trust to actually deliver the vaccine itself. We know from many, many years across public health work in all aspects that peer workers work. If you've got somebody that you can relate to as a human being who understands your context, you're far more inclined to trust them than some outsider, maybe even an outsider in a white coat or an outsider who looks as though they are coming from the state. It's far easier to use peer workers. Religious leaders as well can also be a huge benefit. Information in different languages, including sign language. We forget about people with visual and hearing disabilities. So I think really there's a lot of work that can be done in terms of outreach and taking the vaccine to our vulnerable groups. And I think we'll probably pick up on this later in the discussion. There's a lot of work that civil society organisations like IFA can do to help with that situation.
Absolutely, thank you, Alice. And of course, for emphasizing also the reality on the ground and the importance of trusted sources and non-threatening environments in order to reach these disadvantaged communities. And Valerie, from your perspective in France and with everything that is happening so far, are these issues high on your radar? I understand that the vaccination strategy, the priorities of the vaccination strategy keep shifting in every member state across the European Union. When it comes to marginalized communities, what have your thoughts been on the ground in France, or which are the authorities? Maybe it's on the regional level rather than the national level. If you could enlighten us a bit.
Mm-hmm. So I must say first that vulnerable population, disadvantaged population in terms of poverty, migrants and so on, have not been prioritized as such as the start of the campaign, because when we looked at all the risks, all the factors increasing the risk of having a severe form of COVID, the socioeconomic circumstances as we could approach them were not as determinant as age or comorbidities and so on. So we target all people, over a certain age and with some comorbidities. And you said that priorities have been shifting, but it's not exactly that. They have been extended, when we got more and more vaccine doses. This is what we've done. So, but now what we realized is that in some circumstances, people that should be targeted by vaccination because they are old or sick or whatever, were not reached by the means we developed to get people vaccinated, as you mentioned, because they were not able to take appointments online, or because they are, they have. So we are developing policies to reach out. So what we did, but it's, to my view, it seems to be quite local initiatives, like in Saint-Denis, for instance, which is the department with the most poorest part of the population. Some initiatives have been taken by local authorities and health insurance funds to reach out old people, seniors that were not vaccinated. This has been the case also in rural areas where isolated old seniors, which were not in residence, had been forgotten by or missed by the vaccination campaign. So we are deploying mobile units also to reach this population and or means of transportation. Local governments and health insurance are contacting these people and also organizing transportation to make sure they can reach the vaccination centers. This is the type of initiatives we've built. But very often local initiatives that are very difficult to grasp and to know about.
Yes, and I think that's where also that builds nicely onto what Alice was saying, the importance of working with organizations on the ground and reinforcing them, because they are also closer to the reality on the ground. And so perhaps it can be a mutually reinforcing collaboration between national administration, public administration, and getting closer to the ground. Heidi, looking a bit ahead, is COVID-19 an opportunity? I mean, as Deb was saying, we get a crash course on a daily basis on how vaccines are approved, what's going on with the variants, if we're going to need boosters. Like every single person has become an expert on these issues, and I thought that I was the only geek on Twitter wondering and worrying about these issues. In your experience and in your opinion, is this an opportunity and has something struck you in terms of some promising practices so far? Because also for us in Brussels, in terms of advocacy, it will be useful to highlight and to showcase some good practices so far, also to the EU policymakers.
Yeah, I think it has indeed been a crash course, and we don't want to crash though. But I think that you see the questioning people who probably never knew that it took 10 to 15 years to make a vaccine. All of a sudden, found that and are using it to say, "See, told you so." This is way too quick. But it has been a huge opportunity in terms of increasing awareness about how vaccines are made, how long they usually take. Where I think we've missed the boat a little bit is that we haven't explained why it's happening fast. We say, "Oh, don't worry, it's safe," but or mostly safe, or safe enough. But we haven't said that, well, actually, we have things to celebrate about why it's fast, and that's partly we have new technology starting from the characterization of the virus. And because of the SARS experience, China learned that holding on to that data is not helpful. And this time shared it. And because of technology, they could characterize and share for the scientific global community data about this virus that scientists could start working on, and the different platforms for vaccines, and also the upfront funds from governments in multiple settings and companies was, is totally atypical for a more routine vaccine. And they've also unpackaged the process to work in parallel rather than linear. And by the way, we have so much virus in the world that you can get your clinical trial data quicker than you normally do. So we haven't really talked about that. And I think that we could have done more there and should remember that and maybe start to get it into our narrative if that newness keeps popping up. But I do think that moving forward, people are interested in science. I don't believe that the people who question vaccines or even who are against it are anti-science. They have a very different interpretation of the science. And we've done research comparing which pieces of misinformation get more traction. And it's absolutely the ones that look more like science. The genomic, there's some about this mRNA will turn you into GMH, a genetically modified human, that got way more traction because it looked like a page out of a genomics textbook, even though the caption they put under it misinterpreted it, than some of the other pieces. So they are trying to use science in ways that make their case when there's an alternative view, but they choose the look of science, the approach of science. So I think we have to be careful with bucketing people as anti-science in that sense. But it is a huge opportunity, but it has taught us that we need to do something about the language of science because it's risking getting more rumors out there because it's so inaccessible. And we're not there yet because it's still pretty complicated.
Yeah, and that brings me to a question even from the news of the past few days. For instance, now the European Commission says we will no longer order any more vaccines from AstraZeneca, for instance. And that has been picked up by different media to portray the vaccine as if, this vaccine is not good enough. And this is why they're not going for a second round of a second contract. Deb, you mentioned also Twitter and social media. I don't know, how can we build trust, public trust, and sustainable public trust with these kind of stories? And I don't think that policymakers realize the effect of such announcements even.
I think, I've had to cover things like that. And when you see, restrictions, let's say on the AstraZeneca vaccine to over 55s or over 65s, or in Denmark, it's at all, you have to explain to people that decisions aren't just taken. Decisions are taken of the population of a whole. Denmark, say, for example, smaller population, they might have enough with Pfizer vaccine or the Moderna vaccine, the other vaccines that are available. It might be that so you have to explain that this might not necessarily be about the safety and effectiveness of the vaccine per se, but a whole host of other decisions, supply chain issues, and part of the issues, around contracts is the secrecy of the contracts because of, a sense of vaccine nationalism and kind of bidding wars. And so it might be you have enough supplies of other vaccines. It might be you've decided on you have enough Pfizer vaccine to give to the over 55, so you restrict it to the young. It's not necessarily to do with the balance of benefit versus harm. So it comes back to being transparent and explaining decisions. It might be that those, and I don't know, I'm speculating, that contract was cancelled because there were other supplies coming in, or your population have a preference. There might be all sorts of reasons decisions are made, and the problem is you're given these bold headlines and these bold statements, often without any of the context around it. And then what I find myself doing is having to provide that context just because I feel it's right to communicate it safely and carefully. But not all people, don't forget, you're seeing, and we're learning so much. I'm in a newsroom, I'm on a programme where I am the only person there with a health and science background. I trained to be a doctor initially. And it's amazing watching people's understanding just totally change. I even had a political producer ask me about the sensitivity and specificity of a diagnostic test. And I was like, whoa, my job here is done. you're learning. People don't necessarily understand the context and the nuances, and particularly when so many different journalists are reporting on this from not from science and health. So it's our job really, and I kind of put a medic hat on here. It's our job really to kind of explain it as best we possibly can.
Yeah, but at the same time, I hear you. At the same time, I see on Instagram, people posting vaccine selfies, and that's a sense of pride. And I think this is kind of what we're saying, what we're talking about before, that, vaccines are having a moment. I don't know if it's going to last or not, but Valerie, also for you, we see people also being proud. Oh, I got my shot today, and this kind of positive stories. For instance, in France, where we know that France has a tradition of skepticism towards vaccines. Is this something that you consider in terms of sponsoring campaigns, raising awareness, launching more targeted campaigns? And then I'll come also to Heidi to see if there are some examples where these positive stories can actually make a difference, or it's important they are there because there are so many other negative stories. Valerie?
Yes, I probably don't know all the campaigns that I've been engaged to give positive stories about the vaccine, because HAS is not really involved in that, but you can see some videos, where, for example, where an old grandmother is just dreaming about the future life with her grandchildren and children, living without masks and without, finding the life that we have all forgotten for 1 year. And she is just dreaming during the vaccination, So you have some positive images that we need to convey to make people sure that the benefits of the vaccine really outweigh any of the risks that we can see. But we can, this is the only thing that we can do, because I don't think, like all other panelists, that we should hide anything, but to people, because it will be the worst we can do, I think. But the responsive role of even of media and of about insisting constantly about the risks without clearly showing that the benefits still outweigh the risk for the vast majority of people, for all people even. I think this is where we should insist.
I'd quite like to come in here, and there are risks as well as a journalist doing that. I mean, I obviously work for the BBC, and there's always a sense that if you go too hard in that sense, it's a bit state propaganda, and it can feel, and so I think that there's, and Heidi probably knows far more about this than me, but I think there is a fine balance there, certainly. And and obviously we speak to people, you always want case studies as a journalist, and that then poses other problems. Do you have a case study, N=1 anecdote, single case report of an adverse event? So I think there's an element of caution. I've seen one or two things go out through the media, and it feels, I think for some people, it feels like they're being hit over the head with a bat. So I think there's a careful balance to tread as well.
Yes.
Thank you. Yes, Valerie, you wanna add something?
No.
Okay. Heidi, in terms of positive stories, what is it? Do you think that those are important looking ahead? Also looking beyond the first year deployment of these vaccines.
I think that there are a lot of good stories. I mean, particularly at the community level. I think that in the absence sometimes of pretty weak or actually weak central leadership in some countries, and sometimes worse than weak, misguiding. Local communities, mayors, states, state level initiatives have really come up. And I think that, I mean, I don't know about all of you, but I've gotten to know my neighborhood in ways I never did before. I would, I'd go to work, or I was traveling for work, or, but you have a different community when you're in lockdown, but it's also, you see that there's a mutual support. And I saw people, offering to buy medicines for people who couldn't leave their house because of issues, or pick up food, or, not just the Deliveroo type of thing, but, just, get them things they need. So there is, I have seen a kind of, a very helping, caring side of people come out, which we shouldn't forget. And even in our surveys, when we ask people about would they take a COVID vaccine for their own health or to protect their own health, and then ask the question, would you take it if it also protects other people? It's always higher for the people for willingness to take a vaccine if it has a protective value for others, which to me was good news, that people do have that, community caring bit. But I think there's also been a lot of innovation with who is getting engaged around. Vaccines are typically one of the narrowest, more pillarized pieces of public health. And it's not even within vaccines within broader health, it's specific vaccines. I do measles vaccine, or I do HPV vaccine. It's not even kind of, AIDS is the other extreme of engaging in a good way, engaging all kinds of people. And COVID has given us an opportunity for getting a much broader group of stakeholders. We've got Bangladeshi restaurateurs mobilizing vaccination in the community. They're one of the hardest hit. They want to open their restaurants, but they see that their families, friends, and clients are being hardly effective. Who would have thought that would be one? Taxi drivers are getting involved, barbers, hairdressers. It's a huge opportunity, and I hope we keep those relationships.
Yes, I agree, Heidi. And also, Alice, over to you. I think there is a clear opportunity looking, as I said, beyond the first year deployment of these vaccines, and we're forced to look beyond the first year of vaccines. It is a unique opportunity to get it right when it comes also to these vulnerable populations, and also the role that civil society organizations can play in reaching these populations, in making sure that they get the right information, that they get the right access to the vaccines when they need them, and also to put in place the structures for some more a more permanent, sustainable structure to deal with long-standing health inequalities, isn't it?
Absolutely, Yanis, very much so. Yes, I think there's this certainly opens the ground for us in a very, very big way. A lot of the arguments that we as civil society organisations have been advocating for over many, many years, the basic right to universal healthcare coverage as a case in point, suddenly this pandemic situation is giving us the opportunity to make those arguments more forcefully. I think in terms of what can we do, and picking up particularly, I've seen the question from one of our attendees around this issue of universal healthcare coverage for undocumented people. I think this comes back down to what I was saying earlier around trust. We have to get trust right. So, for example, I know that in the Brussels region, the state is obviously working with other civil society organisations, particularly Médecins du Monde, Médecins Sans Frontières, in order to get mobile clinics, outreach communications to undocumented people. And I think that is a really good example where you've got the state on one hand, but then you've got really well-respected and well-known civil society organisations on the other. And people therefore have a high level of trust. You compare that to the situation in the UK, where the British government said very early on that undocumented people would not be in any way targeted by the vaccine situation. They were encouraged to come forward to get the vaccine. But we also know that the Department for Health has a very long-standing tradition of sharing data with the Home Office here. So we know those systems are talking to each other in the background continually, and there's no mediator in the middle who is a neutral party in a very political discussion that somebody, a person on the ground, can actually say, I trust these people, therefore I will do it. So I think it's a case of building trust. And I think that's where we can really add our voice and help. I think it's a case of us bringing together these different groups, acting as the mediator, becoming that voice of trust, and therefore being able to carry out advocacy towards institutions, and in order to make what can be quite political points in quite a neutral way, and in a way that has trust on both sides, because obviously we have a position of trust in respect of our relationship with state actors here as well. So I think there's a lot of work that we can be doing there. Also more generally in terms of gathering data from, particularly thinking of EFA's membership. We have a very diverse membership, lots of people working with very different vulnerable groups, huge amounts of data that we can bring together as an organisation and understand, unpick, and in order to strengthen our voice when we're making arguments and bring about change in both behaviours on the one hand and policies on the other.
Thank you, Alice. Thank you. I have a question regarding the vaccine passports and the digital green pass, which is something which is debated heavily in Brussels, and it's presented by many as a freedom enabler, but on the other hand, it can also be perceived as a coercive measure, perhaps, that can fuel hesitancy. Heidi, do you have any thoughts on that? And Deb as well, as to reporting around these digital passes, these green passes?
Yeah, I think it's created some confusing language because, I mean, I don't know about others, but I've had this, yellow paper dog-eared vaccine card since I was on my first airplane ride and was quite happy to have it. As a confirmation that, I had the vaccines that you needed. And I think, we should be reminding publics that it's not the first time we've been, aside from school mandates, but, some countries require you to have a yellow fever vaccine to come in. If you want to go on a Hajj pilgrimage to Mecca, there's at least 3 vaccines, and I'm sure they're going to add COVID to that. This isn't the first time in the universe where we're thinking about requiring vaccination for people to access a country or an event. And I think we have to remind people this isn't about you. This is about giving your opportunity to participate. And you can choose not to participate, but if you want to, and in a situation you will put others at risk, then you need a vaccine. But that's not helpful to people who don't want that acknowledgement. I actually think it's become a more conflicted and tense environment because it's digital, because it feels like, which it is, controlled by government, because it is accessible. If you have something that's a piece of paper or a card in your pocket, even though there's probably there's a photocopy of it or some copy in some record, it doesn't feel as controlling. And I think we're coming to a point in human technology tensions, and it's part of the reason the tension around 5G and the tension around GMH. There is a conflictual relationship between people and technology, and adding to that this feeling of being controlled. But I think we should be promoting vaccines like vaccinate, liberate. This is about getting us out of lockdown, out of masks. It shouldn't be put in the same bucket of, protests against lockdown, protests against masks. This gets us out of there. Out of that lockdown, free of the masks. Anyway, just my thoughts.
But I think the element of the digital nature of this is what scares people in terms of data and privacy, but also having two-tier citizens or using it as a discriminatory tool. Deborah?
Yeah, and I think that's where my concerns will come in. I think, and this is again speaking to lots of people, having them on the programme as well. And I think there's question. I think there's an equity question to start off with. If governments in the West, need to keep this up, what happens to equitable distribution of vaccines? Also, the yellow card system. I don't know many people that have a yellow card because they don't have recourse to need a yellow card.
Yeah.
The countries that require yellow fever. I've got one because I've been to countries that require it. The vast majority of people, family, say for example, I'm from Liverpool, have never been to those countries. So it's a totally new concept. The other issue is how it's being rolled out. So in this country, in the UK, I can speak specifically about the UK, it's gone from older risk groups, which seems to be the right thing to do to release the burden on the NHS. But if that then allows you to participate more in society, what about the younger generations who are low risk themselves by and large? How are they impacted in their participation in society? I think in terms of equity, in terms of access, as you've been saying, to vaccine, we know that our communities, hard to reach, or we don't provide the services to them. How are they going to be adversely impacted? From another perspective, I'm slightly uncomfortable. This is emergency use authorization vaccine at the moment. What are the questions about those people who are hesitant already, because, and I've spoken to them, I haven't necessarily broadcast it, this is emergency use, it's not been properly authorised yet, and I'm having to have a vaccine. What do you say? So there's all those, I think, all those thoughts that need consideration. I'm not anti them at all, but I think those questions need to be discussed and considered before going in too hard. At what point do we implement them? Do we implement them after everybody's had an opportunity to get a vaccine? Otherwise you end up with a two-tier system, as you say. I don't know the answer to questions, but as a journalist, they're the questions that I'd like to know the answers, and that's what people are saying to me. I don't have the answers.
No, absolutely. And I think we see a lot of these flashy political announcements. So for instance, you want to go to the Greek islands, you need to have a digital green pass, and this is how it is framed. But obviously there are a lot of points that need to be clarified as to how these instruments can be used, will be used by whom in the future, what is going to be the legacy of such measures. We are coming to the end of our time. I would like to conclude. I would like to ask you, looking forward, and then I will start with Valerie, also from the perspective of a member state, although you don't represent France for the sake of this conversation, but let's say so. What encourages you in the coming months, and what worries you less compared to a few months ago? And that would be my last question to all of you. Valerie, you go first, please. You need to unmute yourself.
So your question is, what are the optimistic
Voila,
views
exactly.
I have on this? I would say that we can learn a lot from this crisis, on vaccines, on policies, on transparency, but also on what didn't work in terms of communication and also media, and how what we can do to counter the negative sides of the story. I still really believe that transparency is needed, and that we all, about all the crash courses we learned from, we spoke about earlier. I think these are positive sides of the story, and I think I have the feeling that the knowledge and the literacy of people has increased, and I think this is very encouraging. I think it should help us to go out of this crisis and improve vaccine confidence. So, but maybe I'm too optimistic. Professor Larson will tell me.
Heidi, now with the legacy of COVID-19, if you were to publish a second book, a second stack, or a stack 2.0, what would be the lessons that you would add? What would be the chapters that you would add to your next book following the experience of 2020, 2021?
I think the title would be Getting Unstuck. Actually, I've had a few requests for a book along those lines. And
there's plenty of material.
Yeah. Well, I hope so, because I think it's, I think it is about the relationship dimension of what the changing relationships that have evolved with state, with companies, with communities, outside of communities, with different types of, because I see very different types of, with public, with science. I've been thinking through it, but I do think it has the potential, if we can hold on to it, to renew a social contract in a different way. We'll see, because I really think that we will be, if recent history is telling, we will be having more pandemic-like situations before another 100 years.
Alice, for you, the past few months and where you see the opportunities lie?
Thank you, Yanis. I think I'd highlight three things. First of all, it's put health right in the spotlight. The public health community has constantly been there, but in the large, we're in the background. We're not centre stage. Now we are. Opportunity, let's really seize that. I think the second point is equity. No one is safe till everybody is safe. And that message is really being played out on a national, regional, international stage at the moment. And that's a good one that we can work with. And the third thing that I'd like to highlight as being extremely positive is the partnership working. I know Heidi was mentioning previously how some of the religious communities have come together in order to assist in terms of getting the vaccine out there. This is great. Let's build on that. We've seen all kinds of new and unexpected partnerships coming to light. We can really use on those and build on them.
Thank you very much. And Deb, over to you.
I think it's again, I would kind of reiterate really what Alice has just said. And there is an opportunity. I think there's an opportunity to improve health literacy and understanding of evidence-based medicine, if that's what you want to call it, of how decisions are made, the complexity of health, also the fact that science can be uncertain, but we sometimes have to make decisions before we've got perfect evidence, and help people navigate health and science really, in kind of and all its nuances and uncertainties, and understand that often scientists disagree. And there is no sometimes single one right answer, and I think it's really building.
I need to say goodbye. Apologies.
No worries. We're 4 minutes late. Deb, please finish your thoughts.
Yeah, and I think it's that really. It's building on, and people suddenly realise this thing called public health, and again, and I think. And again, it's quite use case specific, but those communities, groups that have evolved, the kind of, as Heidi was describing and Alice was describing, how do we make them sustainable? How do we build on them, make sure they're adequately funded to kind of engage with different communities and improve access to healthcare? So I think that there's all sorts of things this pandemic has flagged up, and hopefully we can build on it.
Thank you so much. Thank you. Ladies and gentlemen, thank you for joining us. Special thanks to Alice Chapman-Hatchell, President of IFA and Director of Health in Europe Center, Valérie Paris from the board of the Haute Autorité de Santé in France, Deborah Coyne, BBC Health correspondent, watch her on Newsnight, and of course, Professor Heidi Larson from the Vaccine Competence Project. Please, you will be able to find the discussion online on the IFA YouTube channel, and stay tuned because we have much more coming on this area at the European Public Health Alliance. Thank you so much for joining us today. Thank you for your time.
Thank you. Cheers, Anna. Bye-bye.
Bye-bye.